My final topic for the day is talking about managing diabetes in the elderly, and that's an important group of patients that we all treat. So let me throw some further light on what are the problems that our elderly patients with diabetes have, what are the drug options, with a little more focus on gliptins as a safe option there. So diabetes management in the elderly, the current scenario, we'll be looking at treatment goals, challenges of managing type 2 diabetes in the elderly, drug options, and role of gliptins in the elderly. And we look at all these aspects of overall safety, renal safety, low risk of hypoglycemia, cardiovascular safety, bone health, sarcopenia, etc. So let's remember that the world largely is growing older. The world's old population continued to grow at an unprecedented rate. In 2016, 8.5% of people worldwide were aged 65 and over, which would be defined as the elderly population. This percentage is projected to jump to nearly 17% as the longevity and healthcare improves. We're going to have more and more of our elderly around, and we need to care for them. The global population of the oldest old people aged 80 and older is expected more than triple. So people definitely are living longer and until a late age. Among the older population worldwide, non-communicable diseases are the main health concern, like diabetes. So what is the state of affairs? One of the most common chronic illnesses in the older adults is type 2 diabetes. 1 out of 4 people 65 years and older has been diagnosed or undiagnosed diabetes as per the data in 2010. In USA itself, the cost of diabetes care, both in direct and in terms of loss of productivity, was $245 billion in 2012, with 59% of the direct medical cost attributed to population which was more than 65, which requires more attention and care. So challenges in managing our elderly type 2 diabetes is they may have diabetes of prolonged duration. So there's been a gradual loss of beta cell function over the years. In fact, that's something that we need to keep in mind. Today, our population is being detected with type 2 diabetes at a much earlier age. You have people at 30s, 35s, 40s being detected. So by the time they touch 65, 70, it's going to be much more pronounced, the problem of long duration and declining beta cell function. Longer duration of diabetes and older age also associated with declining renal function. So we know declining renal function, declining GFR is a natural process of aging. This tends to be a little more pronounced in people with diabetes. Efficacy of SGLT2s may be reduced in such patients. So we know that when you have declining renal function in an elderly patient, SGLT2 inhibitors as a choice has its own options in terms of safety, hypotension, bone fractures, and so on and so forth. So what really are the other options that we're looking at? And let me throw some light before I move to gliptins. So metformin would be still considered as a safe drug as far as the renal function is all right and the GFR is normal. If GFR is more than 60, you can use full dose. If it's less than 60, between 30 to 60, you have to use half the dose, maximum up to 1,000 milligram. Lower GFRs may be a contraindication for metformin, especially in the elderly population. What about glitazones? They can be used if you're not considering insulin or SUs are contraindicated in that population. The problem is going to be with edema, and the other problems are, of course, with maculopathy with long duration of diabetes, increased risk of bone fractures, increased weight, especially in combination with other drugs like insulin. So there are some cautions when you consider glitazones also in the elderly population. What about sulfonylureas? Well, can be used. You need to consider more modern sulfonylureas in limited doses, small doses, but there's a lot of caution and worry there with hypoglycemia, again, these patients, and hypoglycemia-related falls and fractures, which become a cause of prolonged morbidity in our elderly population. So sometimes you may consider using short-acting sulfonylureas there, like glipizide in small doses in the elderly population where the other drugs are ruled out. Insulin, well, of course, tends to be an option for all ages. It's just that you need to be a little less aggressive with insulin dosages in your patients with the elderly. May have more social issues about injection technique, affordability, storage, social circumstances, lack of monitoring, which is required when patients are on insulin, and hence insulin too poses a challenge in patients in the elderly age group. So let's remember that beta cell function rapidly declines with age. Let's remember that there is 3 times faster decline in the first phase of insulin release and 2 times faster decrease in second phase insulin release in patients with impaired glucose tolerance, and this continues to worsen in patients as they advance with years of diabetes. So let's look at gliptins as the drugs there and what are the benefits that gliptins has. So some data for sitagliptin as monotherapy in elderly type 2 diabetes patients. So as monotherapy when compared to placebo, we see a 0.7% reduction in HbA1c. This is of course in patients whose baseline A1C, as you can see, is about 7.7. So 0.7% reduction is good enough to get most of your elderly patients to 7%, which is good enough target in your elderly population. Also remember that sitagliptin's efficacy across its studies has been shown to be age independent. So when we look at all the three arms here, which is age less than 64, 65 to 74, and more than 75, the efficacy of sitagliptin has been proven irrespective of the age group of the patients. Well, in fact, sitagliptin has evidence to be more effective in patients with poor beta cell function. And that's, again, the reason that more often than not we consider sitagliptin or gliptins per se in the elderly population because of its proven efficacy and safety. So when you talk about patients who have poor beta cell function as measured by the HOMA beta or the proinsulin to insulin ratio, we clearly see better results with the gliptins in patients who have had poor beta cell or declining beta cell function. This is from the initial study, which was where India and we were part of that, and I've had the privilege to author this paper on the initial study, where a subgroup of patients who were initiated on gliptins, vildagliptin in this case, were the elderly population. So consistent reduction in HbA1c from baseline across age groups. So we see where patients had a baseline A1C of 9.3 in the less than 65 age group, and then a baseline A1C of 9.1 in the more than 65 age group, we still had reductions to the tune of 1.4 to 1.8% HbA1c reduction in the elderly population. Aging in GFR. So as mentioned earlier, GFR declines with age. This decline in GFR is possibly a manifestation of progressive changes in the vascular tree itself. In type 2 diabetes, increasing in GFR during periods of poor control of glycemia, also known as hyperfiltration, is seen temporarily and may be misguiding. And hence, actually to calculate GFR, you need to do that at least 30 days apart to know consistent GFR. Longer duration of type 2 diabetes is associated with a lower GFR. So besides age, it's also the duration of diabetes. And as we can see with increasing duration of diabetes, as we move from less than 1 year to more than 15 years duration of diabetes, we can clearly see that the eGFR values are decreasing. So when you look at eGFR, which is more than 60, which may be 75% in patients with early diabetes, this drops to 57% patients only with a normal GFR. However, good data for gliptins, specifically here for sitagliptin, that all the three dosages are effective in elderly and in all eGFR categories. We need to remember when we use gliptins that most gliptins except linagliptin requires dose reduction based on the GFR, but all of them are found to be safe if used appropriately at appropriate dosage. So no apparent changes in baseline renal function when you look at creatinine and eGFR. So there's no worsening definitely, and in fact found to be safe across the spectrum. Gliptin's effective across the spectrum of CKD. So you're looking here where sitagliptin has been used at 25 or 50 milligram. You can see the efficacy 0.6 in patients with CKD, those with moderate to severe renal impairment, again a 0.8% reduction. And all this is in comparison to a sulfonylurea. So glipizide as the active comparator, you see better results with gliptin, especially in the elderly population with CKD. Vildagliptin has its own evidence in terms of type 2 diabetes patients more than 75 years age with moderate or severe renal impairment. As compared to placebo, we see 1% reduction in the adjusted mean HbA1c as compared to placebo in this patient population more than 75, and in terms of hypoglycemia, a much smaller incidence as compared to placebo. What about effect on albuminuria? So sitagliptin as compared to sulfonylurea has some great data in terms of reduction of albuminuria. So sitagliptin in this large study was found to have associated with the 20% larger urine albumin creatinine ratio reduction as compared to sulfonylurea. So not only is there safety, but clear evidence showing much slower decline in renal function in the elderly population where sitagliptin was used. TICOS, the CVOT for sitagliptin, had multiple outcomes and multiple conclusions for us to really understand. So one of the aspects was looking at the CKD patients in TICOS, and this was 23% of patients in TICOS study had some form of chronic kidney disease. So you saw higher incidence of SAEs and complications in CKD compared to patients in non-CKD, so you need to be overall careful. However, in the sitagliptin group, no evidence of adverse impact on the safety endpoints in CKD patients in the TICOS study, and all these aspects of hypoglycemia, fracture, pancreatitis, and malignancy are clearly listed in patients who are on sitagliptin. Focus on hypoglycemia in the elderly tends to be a huge focus when you're treating our patients with type 2 diabetes. We want to avoid hypoglycemia and avoid all those complications related to hypoglycemia, especially in the elderly. There are its own issues of hypoglycemia in the elderly. It's more difficult to recognize. Symptoms are non-specific. They may go missed. They might not be monitoring. Sometimes it's just misinterpreted as early dementia or age-related symptoms. There may not be any warning symptoms. And there is interplay of multiple risk factors with age, malnutrition, social issues, food, living alone, multiple medications, along with sometimes insulin and sulfonylurea. So you clearly need to give hypoglycemia much more consideration when you consider drugs for managing elderly patients. Sitagliptin and insulin, when used together, it was found to have better glycemic control with less hypoglycemia than insulin alone, and which is where some of you who were attending the panel discussion in the next room earlier, and a case was presented to us. I was clear in patients, even with elderly and CKD, that you will not only use insulin, but try and give them advantage of DPP-4 because of its effect on the alpha cell and reduced hypoglycemia. Clearly benefit when you use it along with insulin to decrease the hypoglycemia. Differential effect of gliptin on glucagon levels. So you see here, this is drug-naive patients with type 2 diabetes, A1C less than 7.5. In terms of response to a meal, when patients are on gliptins, you have decreased glucagon release from the alpha cells, but at the time of hypoglycemia, there's clearly overactivity of the alpha cells, and that's the glucose-dependent benefit that gliptins offer us. Moment there is hypoglycemia, there's much more release of glucagon, which prevents patients from going into severe hypoglycemia. And this largely is because of the synergy between GIP and glucagon. So GLP is useful in preventing glucagon release in hyperglycemia. But when it comes to hypoglycemia, it's essentially the GIP which becomes protective and prevents hypoglycemia by causing release of glucagon when there is an hypoglycemic effect. And that's where DPP-4 inhibitors may have a slightly more benefit than even GLP-1s in terms of hypoglycemia induced release of glucagon. Aging and CVD, again, that's a no-brainer. We've been talking about cardiovascular disease, cardiovascular outcome trials, and as age advances, the multiple risk factors increase the morbidity and mortality due to cardiovascular disease. So old age is associated with worse outcomes. This was also the observation from TICOS, that comparison of event rates in elderly, which was 75, when you looked at data of those less than 75 and more than 75, much poorer outcomes in the elderly patient. However, when we look at the sitagliptin usage in TICOS and that arm where sitagliptin was used, it was observed that use of sitagliptin in the elderly was not associated with further worsening of the MACE, be it the 3-point MACE or the 4-point MACE with addition of hospitalization for heart failure. Glycemic benefit of sitagliptin was nullified in this study in terms of the glycemic equipoise seen between both these arms. Moving on to the other issues of the elderly, fractures. We know that's a concern with our elderly. And clearly patients with fractures, when they have evaluated in terms of problems because of fractures, you looked at heart conditions, neurological disorders, usage of benzodiazepines and use of opiates. One aspect which was a draw home from this analysis was patients with fractures presented significantly lower BMIs than the controls and had a higher rate of declared osteoporosis and comorbidity. So fractures is an issue, but osteoporosis is something which adds to that. What about the fracture risk associated with common medications used in treating type 2 diabetes? So when we look at glitazones, unfortunately a strong association of glitazones with higher incidence of fractures and hence caution in the elderly. SGLT2 inhibitors again throwing up certain safety issues and hence we need to use them with caution in the elderly population. GLP-1 agonists can be considered, but again issues of cost, social aspects does tend to be a problem. Overall usage of GLP being limited for various reasons. And DPP-4 inhibitors, again, when we look at the adjusted hazard ratio or the observed ratio, we see comparative fracture risk being much, much lesser as compared to the other drugs in the DPP-4 segment. So bone safety of sitagliptin in post-menopausal women in type 2 diabetes, and they looked at certain parameters when they were looking the effect of sitagliptin. And they realized that sitagliptin's effect on bone metabolism is likely to be mediated predominantly through bone resorption. So sitagliptin causes reduced bone resorption rather than contributing to any bone formation. And this was seen clearly when they looked at levels of osteocalcinin. So in the sitagliptin arm, that is reduced. They're looking at urinary deoxypyridinolone, again reduced as compared to placebo, alkaline phosphatase reduced, and the bone BMD improving in patients on sitagliptin. So clearly sitagliptin having a favorable effect on bone health, largely by preventing or decreasing bone resorption. Also, gliptins attenuate the decline of skeletal muscle. So sarcopenia seems to be an issue in our elderly, a lot of muscle loss, and that seems to be a problem in the elderly. Any drug which may have beneficial effects there is going to be advantageous. So elderly type 2 diabetes and sarcopenia, what about the role of gliptins in this group as compared to sulfonylurea? When we see the indexes, all the indexes for sarcopenia, the study here concluded that DPP-4 inhibitors in elderly diabetic patients leads to better glycemic and inflammatory control and is also associated with better sarcopenic parameters, preservation of lean body mass, and strength and physical performance indices. So that's an added benefit, a lot of pleiotropic effects that we've been speaking about. We are now getting more specifics about that and the advantages in the elderly. So type 2 diabetes, cognition and dementia, well, that seems to be another age-related problem. Type 2 diabetes through various means would lead to ischemia and other mechanisms, all of this impairing the cognitive abilities in our elderly patients with diabetes. So we need to again look at any drug which may have any positive outcome. So gliptins, improvement in cognitive function in elderly diabetics with or without Alzheimer's. So we are looking at both these categories, and again evidence showing on the basis of the MMSE scores that whether it's patients without Alzheimer's or patients with Alzheimer's, sitagliptin showed significant improvement in their cognitive ability. Gliptins, better treatment adherence than conventional alternatives. So it's easy for you and me as clinicians to keep prescribing drugs, but it's important that we follow up our patients and understand what is making them adhere to therapy. Is it lack of side effects? Is it cost benefit? Is it proven efficacy? Is it more predictable outcomes? I think these are certain aspects which the patients really are the reasons why patients adhere to therapy. And this lovely paper here, again demonstrating that patients on gliptins were associated with better treatment maintenance and lower discontinuation than sulfonylureas or TZDs because of their side effects. So gliptins, again, probably the best options for continued compliance and adherence. So finally, to end my talk, friends, elderly type 2 diabetic patients, certain take-home for all of us at the end of the day. Elderly with type 2 diabetes is a fast-growing population and presents unique challenges for us treating physicians. Therapeutic choices often fall short of desirable efficacy or safety requirements, and I would say safety comes much, much higher there. Gliptin's efficacy is age-independent, I think proven over a decade and a half, a rational choice to achieve glycemic targets, effective even in patients with low GFR, which is commonly associated with increasing age. Low risk of hypoglycemia, which is an absolute welcome benefit in patients who are elderly and prone to more increased risk of hypoglycemia and hypoglycemia-related complications. Generally safe cardiovascular and overall tolerability profile of most gliptins, except few where they might have to consider otherwise in the higher chances of heart failure. Low risk of bone fracture and sarcopenia as seen across for gliptins, specifically for sitagliptin. Positive impact on cognitive decline in the elderly and better treatment adherence for our patients than any other oral anti-diabetic drugs. With this take-home message, I would like to end my talk, and thank you so much for the patient hearing.